of newer nomenclature. Now we are as retina specialists, we are very fond of newer acronyms. So continuing with that trend, now I'm going to introduce you to some more terms here in this talk. Anyway, my talk is on OCT and OCTA biomarkers in retinal vascular occlusions. Now we all know that retinal vascular occlusions are major causes of visual loss, and they require timely diagnosis and management. Now, until recently, clinical findings and angiographic features, they were used to prognosticate and treat these patients. Now, the advent of OCT and OCT angiography, this is revolutionary the way in which we manage these diseases presently. Now, what are the information that you look at? Now, basically, we are trying to look at the macula, which is just a manifestation of the response of the retinal vein occlusion or the retinal arterial occlusion. And we are trying to look at these various features on the OCT. Increased retinal thickness. We are looking at fluid, intraretinal fluid, and subretinal fluid. We are also looking at hyperreflective foci within the retinal tissue. We are looking at vitreoretinal interface changes. We are trying to see how the inner retina is, whether it's opacified. There could be disorganized retinal inner layers, which is called as drill. You could also have disorganized retinal outer layers like loss of ellipsoid zone. So all these are the factors that we look at when in an OCT, and some of these help in prognosticating patients. Now, some of the data that I'm going to present today is from a publication that we published some time ago on retinal vein occlusion. So baseline CFTs. Baseline CFT is an important predictive factor for anatomical and visual outcomes, and this has been established across various studies. But in reality, it is not an excellent tool because it's quite variable. Because a lot of other factors come into play when you want to interpret this finding alone. There is data from the SCORE and from various meta-analysis. It kind of persists. Then across BRVO and CRVO, it has been established that these eyes have poor visual and anatomical outcomes. Now, there is a sign which is called as a prominent middle layer membrane, which is mostly seen in CRVOs and maybe in ischemic BRVOs also, but it denotes increasing ischemia. And this is due to the intermediate capillary plexus and deep capillary plexus ischemia and the adjacent bipolar synapse edema. So this is a poor prognostic marker if at all you happen to see this in your patient. Paracentral acute middle layer maculopathy is a focal area of middle layer opacification that you can see on the OCT. These, again, if present, can be a poor prognostic marker because it is often associated with deep capillary plexus ischemia. Now, one needs to differentiate whether this opacity, middle layer opacity, is very focal, like in PAM that we described before, or is it a diffuse kind of a middle layer opacification? If that is so, then you need to think of an associated arterial occlusion because this is more common in arterial occlusion. So is OCT really useful in CRO? Do you need to do an OCT in CRO? There is a recent classification which has classified CRO into mild, moderate, and severe based on the reflectivity of the different layers and loss of stratification. But we did our own analysis. We found that it was not really useful. There was no correlation with visual acuity, either at presentation or at the final visual acuity. But we did identify some other findings which may be of significance, like the presence of the prominent middle limiting membrane that you see in the white arrow. Now, this is a good prognostic sign when you think of CRAO. It is a bad prognostic sign for vein occlusion, but for CRAO, it is a relatively good prognostic sign because once you see that, the ischemia is lesser in these patients, and these patients may do excellently well, as you can see in the final follow-up. Again, in the right side pictures, you see in a severe ischemia, you don't see the prominent middle layer membranes. Then there is also the concept of reperfusion. Most of the patients, when they come to us, they're kind of reperfused by the time they report to us. So there are some evidence of reperfusion in these CRO eyes. These findings, like presence of intraretinal fluid and subretinal fluid, is now believed to be due to breakdown of blood-retinal barrier as a consequence of reperfusion. Also, ILM detachment has been reported, which is again a feature of reperfusion. So all these are bad prognostic markers. If you see a CRAO patient which has got intraretinal fluid and subretinal fluid or an ILM detachment, these patients are generally bound to do badly. Again, NFAS OCT is also useful. Sometimes you see this kind of a pattern, a fern leaf-like pattern. When you see these patterns, when you happen to see them, these are better prognostic signs as against the globular pattern, the banded pattern that you see in the lower pictures. Octa has revolutionized the way in which we look at retinal capillaries. We know that FA is not enough now because it's two-dimensional. With Octa, we can see 3 layers of capillaries, and we love seeing all these 3 layers and studying them when we see patients with macular edema. Like in this patient, you see there is a lot of leakage at the macula on angiography. You cannot sometimes make out whether it's macular ischemia or not. But look at the Octa, you can very clearly make out that there is significant ischemia, there is FA that is widened. So now we have macular ischemia, and now we know that this is a bad prognostic sign. Now with the SSOCT that we have, we get spectacular images. It just shows us the extent of ischemia that these patients have. Now consider this patient. This patient improved structurally on the OCT, but the visual acuity did not improve. We did an Octa. This is the superficial capillary plexus. You see a nice FAZ. You also see the collateral there. It seems that this patient should have got good visual acuity. But if you look at the deep capillary plexus, you can see that there is ischemia. So there can be a selective loss of capillaries in one of these layers, and this can explain why some of these patients, they don't do well after anti-VEGF therapy. Now, Octa is also useful to pick up abnormal new vessels, which can be missed on a casual examination. Like in this patient, there is a posterior pole new vessels. And we now routinely do ultra-wide field Octa because we now understand that the mid-peripheral ischemia is an important risk factor in these patients. And this may be missed on a conventional fundus fluorescent angiography. And we can get very wide field Octas now. This is the superficial capillary plexus and the deep capillary plexus, very easily studied in these images. We can also map the area of ischemia. The machine gives the fluid void area, and you can calculate the ischemic index. We now know that ischemic index is an important biomarker for increasing ischemia and conversion, for example, of a non-ischemic CRVO to ischemic CRVO. So gone are the days where we just used to traditionally look at the macula. Now we have wide field images. We can pick up more information, new vessels, CNP areas much more vividly in these machines which can do 29 to 29 millimeter wide field images. This is a patient with a wide field image showing collateral, showing good perfusion. We know this patient will do very well. So collaterals are important, and now studies have shown that collaterals are seen much early. We used to think that they appear by around 3 months. It's not so. The collaterals start forming right from the time of the occlusion, and this has been shown, and these patients have good resolution of macular edema. Various types of collaterals have been described, and there are a lot of Octa-based metrics that we use: decreased vessel density, decreased fractal dimension, increased FAZ. All these are biomarkers which tell us that this is we now try to compare the deep and the superficial flow rates, and if the ratio is lower, we know that this is an eye which is progressing towards more ischemia. We look at the ischemic index. We have a value now 30%, more than 30%. It means increased ischemia. We look at the collaterals. So all these are poor prognostic markers. These patients may end up with persistent macular edemas and increased anti-VEGF burden. Now in CRAO, Octa's role is very limited. It helps us to understand non-invasively, a quick glance to know whether the patient is actually reperfused or not. Like you can see these images, the patient is grossly underperfused here. But sometimes when you have a perfusion, it helps us to understand why some of the CRAO patients have good vision and while others don't have. Here you see that the cilioretinal artery seems to have perfused the deep capillary plexus. But you see in the first, on the left side, you see the visual acuity is poor because the foveus is involved. It's not perfused by the deep capillary plexus. Whereas on the right side, you see it is perfused. So it helps us to understand why some of these patients have good or poor vision. But the most important caveat is this, that these patients have poor vision, so the fixation is going to be bad. You're not going to get excellent images that I showed. This is like a day-to-day practice image. This is how you get the images. So you have to be aware of these artifacts. There could be shadow effects, projection artifacts, segmentation errors. So you have to interpret all these findings, putting your clinical skills also into practice. So to conclude, OCT and OCT angiography provides structural and vascular clues that can predict visual and anatomical outcomes. We now have identified certain key OCT biomarkers and Octa-based biomarkers which help us predicting visual outcomes and helps in decision making while treating these patients. Thank you.
Thank you, sir. So how OCTA in a busy OP? I mean, is you just click and the whole white field comes? Because with the montage, it's extremely difficult.
No, one thing is now when some of the machines have the capability to give you a wide field, like the machine that we have. The Interlight is SSO Octa, which is a 4 megahertz processor. So it's very fast. It can, that it is not really beneficial. But my point is that no, there is no harm. Now, when you have a patient with persistent macular edema, and you have tried out your anti-VEGF or switch to steroids, and they continue to have some kind of a mid-peripheral ischemia, there is no harm in doing laser. And then because I think anecdotally, I think most of us have seen patients who have improved a bit. So, but based on trials, no.
No, but in a very important point that in diabetic retinopathy studies, it is shown that it is not targeted laser to the peripheral ischemia. But here there is one more important aspect, as you said, the ischemic index. Now more than 10 disc areas were considered in CRVO study, which is no longer acceptable when you have ultra wide field imaging. It has, you see not 10, 100 disc areas also, it can be so extensive. So these not only for the macular edema regression, of course, what he said makes a lot of sense because there is no harm in treating this peripheral, especially, and also the ischemic conversion happens very high in these patients. Patient going for a rubiotic glaucoma and NVI. So it's very important to pick this, the ultra wide field Octa. Now especially the plexelite of the Zeiss is no more available. But I think Interlight and other imaging machines, especially in vein occlusion, it is very important because without a dye-based angiography, you can see the extent till aura of ischemia, which is, even if ischemic conversion or treating a neovascularization, you need to see the real extent of ischemia before treating actually. Also, one point which Manoj said of prominent middle limiting membrane, but it is seen in both CRAO and CRVO. But then there is a, that is just based on OCT. Now there is a classification based on combining OCT, ONFAS and the Octa, wherein this prominent middle layer corresponds to the perivenular kind of PAM on ONFAS and middle layer ischemia on. So in a CRAO kind of setting, that is the most subtle variant. You see a perivenular or a diffuse PAM on ONFAS OCT, and you see a middle layer ischemia corresponding to the prominent middle hyperreflectivity. That is a more subtle form of central retinal artery occlusion without an clinically evident CRAO. Patient has subtle drop in vision. So that is called OHM1, oxygenation based hypoperfusion maculopathy type 1. Type 3 is the full blown CRAO with inner retinal hyperreflectivity. So it is graded as a more subtle form only involving the middle layer in the cross section and then involving towards the anoxic retina towards the internal limiting ganglion cell layer. So combining these three will give and in CRVO without macular edema, if there is abnormal vision, it's very important to pick up that sign because that will be the only sign of macular ischemia.
Only one last comment is that now it's not that the prominent middle layer sign is not seen in all CRAO patients. It should be seen, but it's more evident in the milder varieties because there is a contrast between this reflectivity and the adjacent reflectivity. Whereas in the severe ones, it's so opaque that you don't see it. So that way, this is a good prognostic sign because it tells you that you're dealing with a milder form of CRVO which is likely to resolve better.
Is there anything that we can do at this stage?
We have actually in the publication where it can either resolve with a almost subtle or thin without thinning, or it can progress to full blown CRAO. So if you pick it up and treat with antiplatelets and I think one patient we have actually heparinized also, came back to see from 6.9, it came back to, it can within a week it can go for full blown arterial.